Good afternoon, everyone. Thank you for joining us today. Welcome to Hope and Healing, Advancing Breast Cancer Care with Compassion and Science. My name is Angela Papalia. I'm the Assistant Director of the Adelphi, New York statewide Breast Cancer Hotline and Support Program, and we have a very special program this afternoon. I'm welcomed by Dr. Ruby Sharma, who is the Medical Director of the Breast Wellness and Cancer Prevention Program, as well as the Cancer, Pregnancy, and Reproduction Program at Northwell Health Cancer Institute. We're very honored to have Dr. Sharma here this afternoon to share her expertise with us. At the end of this program, we will have an opportunity to invite the audience to share their questions in the chat. You'll see the opportunity for your chat below on your screen. Please feel free to enter your information in that chat box, and we will try the best we can to answer all your questions. Today's program is made, funding for our program this afternoon was made possible with support from the CDC, the Junior Coalition of the Manhasset Women's Coalition Against Breast Cancer, and the Northwell Health Cancer Institute. We are very grateful for our community partners. And without further ado, I'm going to invite Dr. Sharma to begin her presentation. Thank you, Dr. Sharma, for being here this afternoon with us.
Thank you, Angela, for such a warm welcome, and I'm really excited to be here. Okay, so we'll try to keep it very simple, informal, and hopefully we'll have enough time at the end to answer questions. Okay, so these are the topics that I'll talk about. Just give me 1 second. I think I have to move this screen on this side so it doesn't block my slides. Okay. Okay, so these are the topics we'll talk about. We'll talk about what is breast cancer, how common it is, what are the causes and risk factors, what can we do to prevent it, what are the tests that we can do to find it early. Then we'll briefly touch upon some treatments, as well as we'll talk about new breakthrough treatments as well as innovations. So we'll start with the definition. What is breast cancer? So this slide here just shows you the normal breast tissue anatomy. The breast tissue has a lot of ducts where the milk flows through. These are the little tiny tubes that carries the milk from the lobules to the nipple. Now the lobules right here, these are the glands that produce milk. And then in between the lobules and the duct is the stroma, that's sort of like the connective tissue that keeps everything together. This is another closer look here, that this is a lobule and this is a duct. If you take a cross section, meaning you cut the duct and you're looking from the top, it looks like a circle like this, which is lined by these normal cells. Now, cancer, the definition of cancer is abnormal and uncontrolled growth of cells. So this diagram here, sorry, my cursor. Okay, so here you see the normal cells are aligned so symmetrically and nicely. But when there is cancerous growth, meaning these cells are growing very fast, very quickly, and abnormally, that becomes cancer. Ductal carcinoma in situ means the cancer that's starting in the duct, and in situ means that it is enclosed in this shell. It's contained within the duct. DCIS, or ductal carcinoma in situ, this is a non-invasive or a pre-invasive cancer, and patients who are diagnosed with DCIS, they usually need surgery, which is curative. And a lot of times then we use some medications to make sure that they do not develop another cancer, meaning for prevention. Now, invasive breast cancer is if this duct is broken and the cancer starts to spread, then it becomes invasive. Invasive breast cancer has a potential to spread to other parts of the body through the lymphatic glands, which are shown here, as well as through the bloodstream. So depending on whether it's starting in the ducts or the lobules, it can be invasive ductal carcinoma or invasive lobular carcinoma. Invasive ductal is more common. Around 80% of the cancer cases or breast cancer cases are invasive ductal. Lobular is less common. but essentially they're treated the same way. Now, how common is breast cancer? Breast common is the most common type of cancer in women in the US. The incidence is around 12 to 13% in women, which basically means 1 in 8 women will develop breast cancer in their lifetime. It is rare in men. Less than 1% breast cancer cases are seen in men, and the chances are 1 in 700 or to 800. But it can definitely be seen in men. It is not exclusive to women. In 2025, estimated new cases are close to or over 300,000 cases, and that corresponds to approximately 15% of all new cancer cases. Estimated deaths in 2025 are over 40,000 patients, which is 6 to 7% of all cancer deaths. I think what's important to see here is that 5% survival rate for breast cancer patients is over 90%. More than 90% patients survive more than 5 years. This graph here is showing you the cases in the last 40 to 50 years have remained pretty much constant. The line is, give or take, it's pretty flat. But this is the death rate, which is slowly going down, which is good news, that in the last 40 to 50 years, we have developed a lot of great treatments and the death rates are declining. Now, this slide shows you that there are certain differences when it comes to breast cancer in terms of different race and ethnicity. Breast cancer is more common in white population, but the death rates are actually worse in African American patients. Some of it has to do with socioeconomic factors, access to care, but a lot has to do with actually genomics and genetics. We see more aggressive subtypes in African American population, and that I think is the most important reason that the death rates are worse. Now, what are the causes? What causes breast cancer? In most cases, we do not know the exact cause. We do not know that what exactly was the insult that caused breast cancer. We feel like that usually it's related to certain changes in the genetic material or the DNA of the cells, which could be related to lifestyle, environmental factors, or aging. Genetic risk. So around or approximately 5 to 10% breast cancer patients have a gene mutation that can predispose them to get cancer. The most common mutations that we know or we talk about are BRCA1 and BRCA2 mutations. For BRCA1 mutation, there is approximately 70 to 80% lifetime risk of developing breast cancer. Usually these patients have more aggressive disease, which is triple negative, and they are very young at the time of diagnosis. BRCA2 mutation, a little bit lower risk to around 60 to 70%, but still significantly higher than general population. And then nowadays, we know a lot about different mutations like PALB2, CHEK2, ATM. There are a lot of different mutations that we can check for. And we can talk about, risk reductions if we know that a patient has a mutation. What are the risk factors? So risk factors are of two types: non-modifiable and then modifiable risk factors. Non-modifiable risk factors means that things that we cannot change. But even having one of those risk factors doesn't mean that you're going to get the disease. So the first risk factor is being a female. Aging, as you age, the risk of cancer goes up. There are certain race and ethnic disparities that we talked about. Now, we know that early menstruation or late menopause also increases the risk of breast cancer. But I would like to focus more on modifiable risk factors, risk factors that we can actually change. So modifiable risk factors, the three big ones are exercise, body weight, and alcohol. We know that if we are very stationary, stagnant, if we don't move enough, that's bad for our health. excess body weight is not good, and drinking too much alcohol is not good. So what can we do to lower our risk? There's a lot of data, a lot of research showing 150 minutes per week of exercise is very helpful to prevent breast cancer, but also in breast cancer survivors, it keeps the disease away. So that usually, if we're doing 30 minutes, 5 days a week, that means 150 minutes a week of exercise. And that's something that I discuss with my patients a lot. Regular walking is not so much exercise, but if you're doing power walking or any exercise where you're huffing, puffing, sweating, 30 minutes, 5 days a week, that is shown to be very, very beneficial. Eating healthy and avoiding weight gain as an adult is also very helpful, and limiting alcohol to less than 1 to 2 drinks per day is also shown to decrease the chances of getting breast cancer. So what are the other factors that put someone at a high risk for getting breast cancer? So we talked about genetic mutations. Other risk factors are having personal history or significant family history of breast cancer. So if someone has had breast cancer once, they are at a slightly higher risk of getting breast cancer again. People who have first degree relative with breast cancer is at a higher risk. So if you have a mother or a sister diagnosed with breast cancer, then that person is at a little bit higher risk for getting breast cancer than general population. Having two family members who are not your first degree relatives, so like two aunts or two cousins, also increases the risk of getting breast cancer. Breast density, which is something that's mentioned on the mammogram report, is a known risk factor for breast cancer. And then having benign breast diseases, meaning atypical hyperplasia or LCIS, those are some other things that put someone at a higher risk for getting breast cancer. Chest radiation before the age of 30 is also a risk factor. It used to be done in the past for certain lymphomas. We don't see it a lot these days anymore because there are other better treatment options for lymphomas. But if someone has had chest radiation at a young age, they should be getting more high-risk screening as they're at a higher risk for getting breast cancer. So what can we do to prevent it? I discussed a little bit about the risk factors that are modifiable, and certain things that you can do, meaning exercise and maintaining a good body weight. But then we at Northwell Health, we have breast wellness and cancer prevention program, where our mission is to educate and empower individuals about their individual breast cancer risk, and to perform risk assessment and then plan a strategy to manage their risk. Patients or people who are eligible for our program are patients with any of these genetic mutations or having a very strong family history, which I discussed earlier, having one first degree relative or two other close relatives, having a family member who was diagnosed with early breast cancer, meaning before age of 50, family history of male breast cancer, as well as family history of both breast and ovarian cancer. All these patients can be seen in our cancer prevention clinic. Then other things that can make someone eligible for the program are high-risk lesions like atypical hyperplasia or LCIS. One of the newer things that's coming up on the mammogram reports is the thyrocusic score. So when someone gets a mammogram at Northwell, they get a text message with their mammogram report. And if you open the message, the report looks something like this. At the very top of the report, thyrocusic score is listed. And if you hover over it, it opens a blue box like this. If someone has a high thyrocusic score, higher meaning 20 or more, then this blue box actually gives the information for our high-risk program. It gives a phone number and an email where patients can contact us to be seen in our program. So high TC score is another high-risk feature that can put someone at high risk for getting breast cancer. and thoracic radiation, which I already discussed. At our center for cancer prevention, breast cancer prevention, like I said, we do risk assessment, we do genetic testing and counseling, we discuss high-risk imaging. So mammogram, sonogram is basic, but patients who are at high risk for getting breast cancer, they can also get MRIs. And now there's contrast enhanced mammogram. That's another approach that we utilize to look for smaller lesions. We also talk about medications to decrease the risk. We discuss lifestyle modifications, and we make referral to see our surgeons if there is a need. This is the information for our program that Angela will, share with everyone on the meeting. Okay, so what are the tests that we can do to find cancer early? So we'll talk a little bit about screening. Screening is a test to find cancer in patients who have no symptoms, meaning you don't feel anything, there is no lump, there is no swelling, but we're doing a test to find the cancer at a very early stage. Mammogram is the easiest way of screening. So mammogram is just a plain X-ray picture, very, very little X-ray exposure. And mammogram, usually the recommendation is to start at age 40. And it helps with very early detection, meaning we diagnose cancer early on, usually stage 0 or stage 1. Patients need less extensive surgeries. We don't have to do mastectomy. A lumpectomy with very good cosmetic results can be done. A lot of times, because this is early stage cancer, we don't talk about chemotherapy or aggressive treatments, and the prognosis is excellent. In New York, most patients are eligible to get 3D mammogram. So I'll talk a little bit about what's the difference between a 2D versus a 3D mammogram. So the 3D mammogram, which is what we do at all the Northwell facilities, is the picture is taken not just like straight up, but the tube rotates around the breast. So instead of getting one image, there are multiple little slices of pictures that are taken. Sorry, it increases the detection rate by 40% and also reduces false positive. Now, this is just an analogy to show you the difference between 2D versus 3D. 2D pictures, you're looking at this deck of cards from the top, and you're just like, seeing one image, versus 3D is like when the that deck of card is played and you can see a lot more pictures. So it just helps with more detection. Breast ultrasound is done if the screening mammogram is abnormal, and it can also help detect early stage cancer, especially in women who have dense breast tissue. MRI is done if someone is either diagnosed with breast cancer or if they are at high risk for getting breast cancer. Mammogram and MRI, they both can be done once a year, and they are usually spaced out every 6 months. So if someone got their mammo in January, they will get their MRI in July, and that helps with close monitoring. Now, contrast enhanced mammogram is a relatively newer technique where it's a mammogram picture, meaning it's an X-ray picture, but the patient is injected with an iodine contrast to help with better visualization of the lesion. It's usually, it's definitely better than a plain mammogram, but it's almost similar to MRI in terms of cancer detection. MRI, if anyone has had it ever, it's a very long test. It's, claustrophobia is a big issue. And it's also somewhat, uncomfortable. You have to lie on your belly. So if a patient is not able to get MRI for any of those reasons, then contrast enhanced mammogram is a very good alternative. So screening definitely is important, but if someone develops any of these symptoms, that needs to be addressed immediately. So any new lump, swelling, nipple turning inwards, or if there is any redness or thickening of the nipple discharge, pain in the breast, swollen lymph nodes, any of these symptoms, they need to be addressed immediately. Okay, so we'll talk a little bit about treatment. Treatment depends on, most importantly, on three receptors: estrogen, progesterone, HER2. Estrogen and progesterone are the female hormones, HER2 is a protein. Treatment also depends on the stage of the disease, meaning how big is the tumor and what's the status of the lymph node, if the lymph nodes are involved or not. There are different treatment modalities, and we'll discuss all of these modalities briefly. Surgery, meaning cutting out the cancer tissue. Surgery can be done either as lumpectomy, meaning removing the lump, or mastectomy, meaning removing the breast. It helps to get rid of the visible cancer, meaning the cancer that you can see. Surgery will remove it. Treatments that are done after surgery: chemotherapy, hormonal therapy, immune therapy, radiation therapy. These treatments are focused on killing the microscopic cells, the cells that you cannot see. Chemotherapy basically means, medications that is given through the veins to kill the microscopic cancer cells. Hormone therapy is usually in the form of pills or injections to block the hormones which are feeding the cancer cells. Immune therapy is also an IV medication that trains your body's immune system to fight the cancer cells. And radiation therapy is basically, these are high energy rays like X-rays that you don't see or smell or feel, but they kill the cancer cells in the area where the cancer was present. It's typically done after surgery. So let's talk a little bit about surgery. So this is how a lumpectomy looks. The tumor right here, usually our surgeons, they open the area with a very small incision, remove the tumor with a little extra tissue around it to make sure the margins are clean. Now, this is from an old textbook, so the scar is right here. But a lot of our surgeons are doing scars right around the nipple areola, so when it heals, you don't even see the scar. But usually there is, some scarring depending on the location of the incision. There is some scarring present. Let me just adjust this. I'm sorry, 1 second. Okay. So this is what a mastectomy looks like. When our surgeons do mastectomy, they remove the breast tissue, they remove some of the lymph nodes up here. And if there is no reconstruction, this area looks flat. But we have excellent plastic surgeons these days. They can make another breast, usually with the abdominal tissue, or they can put an implant and it looks exactly the same as a natural breast. Sentinel lymph node. So sentinel lymph node procedure is done to basically look at the lymph node and make sure that there is no tumor involvement there. When the patient is getting surgery, the surgeons, they put a little dye in the tumor area, and depending on the lymphatic drainage, the lymph node that's directly connected to the tumor tissue, it lights up. And then as we remove the lump, we remove this lymph node to make sure that there is no cancer cells that have traveled there. It's a very standard procedure. It leaves a little scar like that, but it definitely, makes sure that all the cancer tissue is removed. If someone has cancer present in the lymph node, sometimes they get axillary lymph node dissection, meaning removing a lot of lymph nodes. We try to avoid that procedure if we can, because removing the lymph nodes can put someone at risk for lymphedema, which means the swelling of the arm. So if this is a normal arm, lymphedema can look like this. The arm, the hand, everything is swollen. It's painful, of course. It puts patients at risk for getting infections. It limits the range of motion, and it really affects the daily quality of life. Lymphedema, if it happens, it can be treated. Patients can wear sleeve, they get some physical therapy, and it can definitely, be treated, but we try our best to avoid these complications if we can. Now we'll talk a little bit about systemic therapy. So these are all the drugs or all the chemotherapy drugs that are available to treat breast cancer. I'll just talk about, a few of them. Some of them are used in, patients who have had surgery with curative intent, meaning the cancer has been removed, but depending on certain characteristics, we feel like there's a high risk of cancer recurrence. And then we use either, adriamycin-based chemo or sometimes taxane-based chemo to decrease the risk of relapse or to decrease the risk of recurrence. Adriamycin is also known as red devil. It's a very effective medicine, but it also has side effects. It's red in color, and patients usually see this red medicine getting infused over 5 minutes or so. They feel certain side effects, and hence the name red devil. My job, my team's job is to make sure that the side effects are manageable. We do certain tests beforehand. We help our patients get through these treatments. Chemotherapy, it's no joke, it's no walk in the park, but it is manageable in terms of side effects for a patient who really needs it. We do a lot of, testing on the tumor to make sure that we're offering chemotherapy to patients only when they need it. It's not done for every patient. It's only offered if someone really needs it. Other medications like taxanes, they can cause neuropathy, which we monitor. Some of the drugs here are used for metastatic breast cancer. I think what I want to highlight here is the number of options we have. We have so many options, and the options, are every year or so we get, a few more new drugs, and that just helps, with more treatment options for our patients. What about other options? So patients who have estrogen positive breast cancer, they receive endocrine therapy, which traditionally there are two types. One is tamoxifen, and the other is aromatase inhibitors. Depending on the age, depending on the risk factors, we discuss which option is the best. In the last, let's say, 7 years or so, we have two new drugs that we use in addition to aromatase inhibitors. One is Kisqali, the other one is Verzenio. These medications are used for patients who we consider are at high risk for getting recurrence. So if someone, who has either like a large tumor or positive lymph nodes, we offer these medications in addition to the traditional aromatase inhibitors to decrease the risk of recurrence. And the combination of, Kisqali with aromatase inhibitors has really shown to be very, very effective in keeping the cancer away. Now, there's a newer class of drug that's been coming out, and elacestrant was approved a few years ago, and then two other drugs, camizestrant and imlunestrant, got approved recently. This is a totally, new category of drug, and there was another SERD, or selective estrogen receptor degrader, which has been in use for many decades, but it's an intramuscular injection, very painful injection. So in the last few years, some of the drug companies have come up with an oral version of that medication. And right now it's approved for metastatic breast cancer, but there are a few clinical trials going on to use these medications, again, in combination with aromatase inhibitors for patients who have early stage disease. So someone who has stage 1, 2, or 3 breast cancer, we're using combination therapies to decrease the risk of recurrence. Lupron is, an injection that we use, again, in addition to some of these medications to stop the periods. Now, targeted therapies. Target meaning, either estrogen or HER2, these targets, if they're positive, we can use certain medications to block the target. So HER2, like I mentioned earlier, is a protein. If it is present in breast cancer, meaning if someone has HER2 positive breast cancer, HER2 blocking drugs are really, really helpful in the adjuvant as well as metastatic setting. So the first drug that was ever approved for HER2 positive breast cancer was trastuzumab, or Herceptin. This is going back almost 25 years that that Herceptin was approved, and now we have multiple similar drugs that are used sometimes in addition to trastuzumab, and sometimes, if trastuzumab doesn't work, then we use other drugs. But basically, when we found out about HER2 protein, the only thing we knew was that it makes tumors very, very aggressive, and people were not doing well. But now that we have so many wonderful HER2 blocking drugs, we feel like that the prognosis for HER2 positive breast cancer patients, it has improved so much. It has improved significantly, to the point that sometimes we even downstage them. If someone has HER2 positive breast cancer, sometimes they are downstage, in terms of our staging system. Now, PARP inhibitors, that's a very special category of drug. It is a drug specific for patients who have BRCA1 or 2 mutation. So someone who has a genetic mutation and high-risk breast cancer, they can get olaparib as an option after completing their other treatment. For patients who have metastatic breast cancer, we do a lot of testing for a lot of different mutations, and PIK3 is one of them. And if the patient has this mutation, they're eligible for drugs like PIK3 and TrueCap. Immunotherapy is specific to triple negative breast cancer. So triple negative breast cancer is the most aggressive breast cancer, and the options are limited, but immunotherapy has been approved for the last, I think 5 years or more, and it's been really, really effective for triple negative patients. Now, as we offer all these treatments, we do see sometimes side effects that are very difficult to manage. So at Northwell, we have menopause clinic. We work with our cardio oncology program, rehab medicine program, as well as oncofertility to manage some of these side effects. A little bit about radiation therapy. So radiation therapy used to be, for the most part, like 4 to 6 weeks for most patients. I'm talking about maybe 15, 20 years ago. Now there are a lot of different radiation schedules, more targeted radiation treatments, and very short treatments. Like I sometimes see that patients are only getting, 5 days of treatments instead of 3 to 4 weeks. And their machines are very sophisticated. There's a lot of advanced planning that our radiation oncologists do to reduce any damage to the heart or lungs. And in general, our patients have better quality of life post-treatment. Young onset breast cancer, this itself is like a 1-hour topic, because we're seeing more and more patients who are getting diagnosed at a very young age. Young meaning, under 40, and approximately 15% of breast cancer cases are diagnosed under age 40. The treatments are pretty much the same, but I feel like they go through different kind of, their own complications because of their young age. Fertility after cancer diagnosis is a big thing. A lot of these women, they still want to get pregnant after their breast cancer diagnosis, and we work with oncofertility department at Northwell, where we can freeze their eggs or freeze their embryos prior to starting their treatment. There is some data that, depending on the tumor type and stage, that these patients can take treatment for 2 years or so. Then they can take a break from treatment. They can successfully get pregnant and then resume treatment. This approach is shown to be safe for, not for all patients, but certainly patients with early stage disease. We do see patients who get cancer while they're pregnant. And that is a real challenge. That is a real challenge to treat someone, treat someone's cancer when they're pregnant, because we're not just trying to save the mother, but we have to make sure that the treatments that are being offered, they're safe for the fetus, for the baby as well. So we have, Center for Cancer, Pregnancy, and Reproduction at Northwell, where we take care of these very complex and challenging cases. Some of the breakthrough and innovations. So HER2, when we started talking about this 25 years ago, roughly, we only had two categories, HER2 positive or HER2 negative. But in the last few years, HER2 low is a new term. HER2 low means that they are not HER2 zero, they're either 1 plus or 2 plus, but they're not also positive. So it's sort of like an in-between expression of the HER2 protein. This is a very important thing to check for our patients who have metastatic disease because it opens up some new treatment options. So this is something, that we have been checking for all our patients with stage 4 disease. If they have HER2 low status of the disease, they can be treated with a very effective, very helpful medication called Enhertu that has shown to be very, very successful. Precision medicine, most of our patients who have stage 4 disease, we do some special testing on their tumor to look for certain gene mutations or to look for certain actually mutations in the tumor itself. ESR1 is one of them. I talked about PIK3 mutation a few slides ago. And these mutations basically, again, open up more, newer treatment options. De-escalation strategies are also very important because we feel like sometimes we're just pushing more and more treatment. But patients who have low-risk disease, they don't need to be treated the same way. So de-escalation strategies in terms of surgery is very important. I talked about sentinel lymph node, but not everybody needs sentinel lymph node. If someone has a very small tumor, if they are over the age of 60, a lot of times our surgeons, depending on how their mammogram films and how their MRI is looking, a lot of times our surgeons don't do sentinel lymph nodes. And that's because, sentinel lymph node does cause pain and mobility issues later on. So we're trying to de-escalate surgery if possible to decrease all these quality of life issues. Now, excuse me, clinical trials. So this is a list of clinical trials that we currently have available at Northwell. Just want to highlight multiple clinical trials that are available to provide newer options. Northwell just opened a START program, which is where we provide access to phase 1 clinical trials, meaning very early clinical trials for some of these newer medications that are not available elsewhere. Circulating tumor DNA has been a topic of debate. For certain other cancer types, circulating tumor DNA is checked regularly, but in breast cancer, it's still in clinical trials. We don't check it on a routine basis, and it hasn't been, very, very helpful, at least as of right now. In terms of supportive oncology, there are a few newer medications to help with hot flashes, which is a very common symptom in patients who are taking endocrine therapy. I can't pronounce this name, but the medication is very helpful. And Dr. McNally, who runs our menopause clinic, she prescribed this medication. I think the easier name is Veoza. Prescribe this medication routinely, and a lot of my patients who take it, they're very happy. Once the hot flashes are better, it just, everything starts to feel better. And I think with that, this is the message of the day. Every day is another chance to get stronger, to eat better, to live healthier, and to be the best version of you. And with that, I'll take questions.
Thank you so much, Dr. Sharma. This was an incredibly informative presentation, and there's so much that's happening at Northwell at the center. It's very exciting and very hopeful, and I truly appreciated you taking us through the different facets and the different types of the treatments, screenings available. There's so much to cover in such a short time. I'm going to invite the audience to please put into the chat your questions so that I can pose those to Dr. Sharma while we have her on the call. I did want to bring up um, so many things, but one of the points I wanted to ask you about was the START program that you had just spoken about regarding phase 1 of clinical trials. For patients that are at different stages of a breast cancer diagnosis, how would they go about accessing the clinical trials available at Northwell, including the START program? It looked like such a comprehensive list, and I know we'll have access to this at a later time, but can you speak a little bit about that and what that process would look like for patients that maybe are in treatment but would like a consultation for a clinical trial at Northwell?
So the easiest answer is talk to your provider. If you speak to your medical team, your oncology team, they will tell you what clinical trials are applicable to you. For early stage cancer, of course, there are phase 2 and phase 3 trials for the most part phase 3, but the START program especially is for mostly for metastatic patients. Metastatic patients, they go through multiple treatments that are approved, and sometimes they reach a point where there are no more treatment options that are available. And at that time, I feel like, to try something new, try something that's not approved yet, but we know it's safe enough to try, is the right thing. And that's where START comes into picture. So if you speak to your provider, your clinical team, they will definitely, help you answer that question.
Thank you so much. A few things coming into the chat. The first question is about research with respect to a cure. Can you speak to anything that's coming down the pike and new and innovative research that may be going on right now, looking towards a
So
cure?
clinical trials, right? That is research. If cure for early stage cancer is, the cure rate is very high, over 90%. And that's just based on the current, treatments that are available. But of course, we want newer treatments. And that's why we actually encourage most of our patients to participate in a clinical trial. So research is ongoing um, based on some positive research. Some of these medications have been approved in the recent past. So medications, based on ESR1 mutation or based on PIK3 mutation, oral SERDs, those are all the medications that are available based on recent data that was published. And there's a lot more that's, ongoing.
Thank you for sharing that. That's much appreciated. People are interested about the the menopause clinic at Northwell as well. Is that exclusively for patients at the cancer center? Is that for the general public? Can you speak to that a bit?
Anyone can go there. You don't have to be even a cancer patient to go there. I think, if people just Google menopause clinic at Northwell or speak to their provider, they can be referred to that clinic. Dr. Stephanie McNally, she runs the clinic, but then there are other doctors in that practice, who can see the patients. And she is, a lot of times if it's not easy to make appointment in that clinic, you can just also discuss with your OBGYN that what are the options that are available for menopause symptoms.
I think that's incredibly helpful. There's so much more discussion in our society today than there was previously regarding menopause and how women can be empowered to really take charge of their health and their experience. So this is very exciting. There are some questions about menopause, and just to provide some framework, if you're able, with respect to a typical menopause stage in a woman's life. One of the audience members is asking about what age is considered late in terms of her entry into menopause.
So menopause can happen between the age of 48 to 53. That's considered sort of average. After 55 is considered late. And, it depends on a lot of factors. I think, for a lot of people, it's genetic. I hear this, from my patients often that, oh, my mom and my sister were still menstruating at the age of, 55, and I'm doing the same. So, there is definitely a genetic link. But the average age is somewhere between 48 to 53. After 55 is a little late, but I definitely see patients with breast cancer when their menopause was at 45. So even though it increases your risk a little bit, it's not the only thing that would put someone at the risk of getting breast cancer. Meaning, it's not necessary that if someone went into menopause a little bit later than 55, that they're at very high risk of breast cancer. That's not the case.
Understood. Thank you for providing that clarification. One of our guests is asking if she had a genetic testing that showed a variant of indeterminate significance. Should her 39-year-old daughter be encouraged to have genetic testing? And we can, go ahead.
So variant of undetermined significance or unknown significance are treated as a negative result, meaning treated as like, as if there is no mutation that's driving the cancer risk. Okay. Now, usually we encourage the patients to check in with their genetic provider every 2 to 3 years or so, because depending on, so the company who ran the genetic testing, whether it's Ambry, Myriad, they pool the data, and every 5 to 10 years, they will update the results depending on that particular variant that was listed as undetermined significance. If a lot of patients did not develop cancer later in life, then it means it will be downgraded to normal variant. Versus if they see that with that particular mutation, with that particular variant, a lot of patients ended up getting cancer in the next 5 to 10 years, then they will upgrade it to a pathogenic mutation, right? So, if you keep checking with the provider that are there any updates to my results, you will find out in most cases, these results are downgraded to normal, meaning like there is no increased genetic risk. But in the moment right now, if you just know that, it's a VUS, it's considered as negative. So the family member, whether it's your children or other siblings, they do not need any, a high risk screening just based on the genetic result. If there are other risk factors like family history of cancer, etc., the daughter may still qualify.
That's very helpful. Thank you. We have someone who's asking regarding the length of taking medication. How long is a metastatic breast cancer patient who has no evidence of disease for 6 months expected to take Xeloda? So this is a very specific question. We could maybe even generalize it a little bit, but for someone who has no evidence of disease but does have metastatic breast cancer, is there an expectation or recommendation for how long that person should continue to take the medication?
I get this question a lot, and the answer is for as long as the treatment is working, you're going to take it. Metastatic breast cancer, it basically means that the cancer cells have already started to travel through the bloodstream. All right. So if you're taking any particular medication, whether it's Xeloda or any medication, if it's working, it means that it's suppressing those cells. So, you should continue the treatment. And, usually these patients are getting scans every 3 to 6 months, 4 to 6 months. If there is progression at any point, of course, then the provider will change the treatment. But I hope that this treatment will stay effective for a really, really long time. Okay. It's, I know the patients usually want to hear that you can stop the treatment if there is no evidence of disease on the scans, but unfortunately, that's not the right answer.
Thank you for sensitively addressing that. There are several questions with respect to neuropathy. Can you speak a little bit about symptom management of neuropathy? Because that's something that we hear about all the time, and how difficult and debilitating that could be.
So neuropathy, especially, with taxanes, it can be permanent. So it can be very disabling. And when patients are getting chemotherapy with Taxol or Taxotere, Usually their care team, care provider, they're checking in with them every 2 weeks or so to see if there are any symptoms, any beginning of neuropathy. Usually, if someone starts to develop neuropathy that's permanent, we're not talking about disabling symptoms yet, but just some sensitivity, tingling, numbness, but it's permanent. Usually I recommend that we cut down on the dose so that it doesn't continue to progress. So we either cut down on the dose or stop the treatment a little prematurely, because if this neuropathy continue to progress, it starts to affect the quality of life in a very significant way. People cannot type, sometimes they cannot walk, multiple frequent falls, etc. So it can be a very big problem. So I hope, when patients are getting treatment, they are in touch with their provider to discuss, these symptoms, so it doesn't progress to really like bad neuropathy. But if someone has even mild neuropathy, tingling, numbness, or, painful neuropathy, it can be treated with some medications like gabapentin, Cymbalta, to provide some relief. Most patients feel like they're always like numb, they don't have sensation, and it's annoying. Um, but yeah, the first thing is to make sure talk to your provider so it doesn't progress to a very disabling level. And there are some medications that you can use to help with symptom control. Unfortunately, it can be permanent.
Thank you for speaking to that. I think one of the important points, one of the many important points that you have the takeaway with respect to the neuropathy is the importance of talking with your doctor as things progress for patients that are undergoing chemotherapy, to not undervalue the importance of bringing up symptom management and how one is coping with side effects week to week, month to month, because there may be things that can be done to adjust the treatment and therefore help the patient manage those symptoms. So I do appreciate that. That's something that we hear often from people in the community. There was a question about genetic testing. Someone is asking what that experience looks like. Does it consist of blood work, scanning, and the importance of genetic testing?
Genetic testing can be done either with the oral swab. So sometimes, if you meet with a genetic counselor on a video interview, they will mail you a kit where you can just swab your mouth and can send it back. So it can be as easy as that. But if you are seen in an office and you're already there, genetic testing can be done as a blood test also. Once it's done, the results take 3 to 4 weeks to come back. And then, once you get the results, and if they're positive, then your genetic, the care team, they will discuss with you that were the cancers that you're at high risk for and what can be done to address the risk. Sometimes it's surgery, sometimes it's like, enhanced screening and things like that.
Thank you. There is a question regarding hormone replacement therapy. Our guest has shared HRT has been previously considered as something that could possibly increase one's risk of developing breast cancer. Now, there's some studies that suggest HRT is good to lower the risk of Alzheimer's disease. Can you speak to that at all? Is that something that has come up?
That's the most dreaded question for a breast oncologist.
I'm so sorry.
No, that's okay. But I get this question not only from, my patients, but also from my friends a lot. HRT, I think it's really, it has to be a very individualized approach. Depends person to person. If someone is at high risk for getting breast cancer or already has breast cancer, history of breast cancer, then HRT is risky. If someone has a family member, like for example, mother with estrogen positive breast cancer, putting in extra hormones can be harmful, right? Same thing if they have personal history and they're taking they're taking medications to block the hormones, then taking HRT is doing totally opposite of the treatment. So that's like counteracting the treatment. But for an average person who is not at high risk for getting breast cancer, who has never had breast cancer, if they have a lot of menopausal symptoms, They can take HRT for a defined period of time. Usually it's like a few years, it's not forever. Even for patients who have breast cancer and they're taking hormone blocking treatments, sometimes we let them use, for example, vaginal estrogen to treat, extreme vaginal dryness. So we can sometimes, let them use some sort of hormones, but it's really case by case basis. So for someone without any significant risk of getting breast cancer, I think they can certainly discuss with their gynecologist.
Thank you for addressing that very challenging question. Thank you. I think I appreciate your openness to responding to our community here today. A few messages are coming in. We have just a few moments left. Someone is asking about Northwell accepting new patients for genetic testing. And I believe we did have some additional information in the chat how to reach out to the Center for Menopause and Midlife Health at the Katz Institute for Women's Health. Would that be the best place for people to reach out who are interested in genetic testing, or is it right to the Cancer Center, Dr. Sharma?
They can reach out to the Cancer Institute. So Northwell has two types of genetic screening program. One is for sort of like all genetic issues, and one is specifically for cancer genetics. So Dr. Kauf, he leads the cancer genetics program, and if someone wants to reach out to the Cancer Institute and just ask for genetic testing appointment, they can get the appointment that way.
Terrific. Thank you. And one last question to be mindful of your time and everyone else's. There was a question regarding the neuropathy for patients that are many years post-treatment that continue to struggle with the effects of neuropathy. Are there any innovative treatments available to patients that continue to try and manage this years past their treatment has finished?
Unfortunately, not. Nothing that I can think of. There is really just, the medications that we use, like gabapentin and Cymbalta. Those are the medications that would help minimize the pain that comes with neuropathy. But that sensation of, not able to feel cold, hot, or not, just feeling numb or and crawling under the fingertips, those sensations, unfortunately, they just stay there. So definitely, an area where we need to do more research.
Well said. Thank you so much, Dr. Sharma. It's really been a wonderful opportunity to have you here today, and we so appreciate your time. We know how very busy you are, and on behalf of all of us at the Adelphi Breast Cancer Program, thank you for providing your expertise this afternoon. And I invite the audience to please complete the evaluation that you will receive shortly after this program resumes. We're very excited to have had Dr. Sharma here, and we're grateful for our partners over at Northwell Health. If anyone at any point needs the services at the Adelphi Breast Cancer Program, please reach out. Call our hotline, 1-800-877-8077. You are not alone. And on behalf of all of us here at the program, Dr. Sharma, and to our audience, thank you so much. We wish you a wonderful day. That concludes our program.
It was my pleasure.
Thank you.
Okay.
Be well, everyone. Thank you, Dr. Sharma.
Thank you. Bye.
Bye-bye.